Now talk about thermal ablations of the varicose veins. I have no conflict of interest. The prevalence of varicose veins is estimated to range from 2% to 40%, so the very common disease to affect the population. Treatment of varicose veins can roughly be divided into mainly two modes of treatment, either endovenous thermal ablation like laser, radiofrequency, microwave, and steam, or non-thermal ablation like foam sclerotherapy, mechanical occlusion, chemical assistance, which we call it MOHP, and cryoclade ablation or glue ablations. In the last 20 years, endovenous thermal ablation procedures have become the most frequently used therapy for saphenous varicose veins. These such minimally invasive techniques meet the demands for cosmetically superior, less invasive, and more successful treatment options. Let's talk about the technique. We use ultrasound to guide all the parts of this technique. Firstly, we use ultrasound to access the vein and localize the vein for venous puncture. Then we guide the caster inside the vein. Then we position the tip in its optimum site inside the vein. Then we use the important part in our procedure, which is tumescent anesthesia infiltration around the vein. Then final tip positioning. Then after we finish, we confirm the success of our procedure. Here's a video showing us how we use ultrasound. We localize the vein on the skin of the patient. Then after we localize the vein, we puncture the vein under ultrasound guidance, then introduce the wire, then the sheath. Here's some video about the procedure. Firstly, we do local anesthesia at the site of puncture. Then we use the ultrasound to localize the vein. Here is the saphenous vein in longitudinal section. We start puncturing the vein. Then after we are sure we are inside the vein by getting a backflow from the needle. As you can see here, here is backflow from the needle. We introduce the guiding wire inside the vein. You can see here nicely that the vein is inside the wire with no punctures or no problems. After this, we introduce the introducing sheath inside the vein for application of the thermal casters. Then we introduce the thermal caster inside the vein. We position the tip of the caster away from the common femoral vein by 2 centimeters at least, according to the recommendations, or just before the orifice of the superficial epigastric vein. Here, the optimum site of positioning of the thermal caster to prevent injury of the deep vein, the common femoral vein. Then we start the most important part, which is infiltration of the tumescent anesthesia surrounding the vein. This is placement of large volumes of diluted anesthesia in the perivascular position under the direction of ultrasound. It serves several purposes, mainly to protect the perivascular regions from heat injury or thermal injury, and the decrease or compress the vein surrounding the caster to optimize good ablation. And also, under the effect of anesthesia, it reduces the pain for the patient. So this procedure is done without any anesthesia, only with local and tumescent anesthesia, and the patient, after end of the procedure, go back home without any hospitalization. Here is the ingredients of the tumescent anesthesia solution, which we call it cleansed standard tumescent solution. The average amount of tumescent fluid around the vein is between 8 to 10 milliliter every centimeter of the vein. There is the optimum amount of tumescence. Here I will show you how we do the tumescent anesthesia. We also use ultrasound to localize the vein. Here the caster inside the vein, our needle. Then we infiltrate or pump large amount of fluid surrounding the vein, as you can see here. The fluid fills the saphenous compartment, compressing and surrounding the saphenous vein. You can see here in this image that there is a ring or a donut surrounding the vein, as you can see here. This is the image of an optimum tumescent surrounding the vein. There is no tissue touching the vein, and the vein is compressed and surrounding the caster. When we reach the terminal end of saphenous vein at saphenofemoral junction, we have to place a large amount and good amount of tumescent anesthesia surrounding the vein. Even we inject a good amount of tumescent fluid deep to the vein to separate the saphenous vein from the common femoral vein adequately to prevent any heat injury to the deep vein. As you can see here, we inject good amount of tumescent deep to the caster and the saphenous vein at the saphenofemoral junction or the termination of the saphenous vein. Then we do a saphenous ablation. Now we'll go to different modalities. The first modality I'm going to talk about is radiofrequency ablation. Here is the appearance of the caster of the radiofrequency. Is the most common one we use is made by Medtronic. It's an American company. You can see here that the caster having a long heating element. This heating element is about 7 centimeter in length, so it's a segmental ablation of the vein. We ablate 7 centimeter by 7 centimeter in this procedure. Here is the caster. We first measure the length, estimated length of the vein on the patient leg. Then we introduce the caster inside the introducing sheath to position the tip of the caster by ultrasound. As I mentioned, it's in its optimum position before the saphenofemoral junction. Then we start the ablation. We ablate 7 centimeter by 7 centimeter, and here is the mark on the caster. This mark is separated from its previous mark by 6.5 centimeter to ensure overlap between the ablated area. We do a compression by ultrasound probe at the site. Here is the machine. The cycle of ablation is about 20 seconds, and the manufacturer recommends at the proximal part or the part near the junction, we give 2 cycles, then 1 cycle every part of the vein. We finish then the vein. Here is the ablated part of the saphenous vein. We reach the terminal end, we remove the sheath and ablate the last part of the vein. Let's talk about laser, the second modality and the most popular modality in ablations. We have several wavelengths, either hemoglobin afflated, like all these mentioned wavelengths, and the newer one is for water specific laser, mainly 1470, and the newer one is 1927 nanometer wavelength. The hemoglobin specific laser wavelengths lead to steam bubble formation, which secondarily induces thermal damage to the intima. The hemoglobin specific laser generation have been used with a bare tip fiber, the old fiber, which may lead to perforation of the vein. So although this mechanism is effective in vein obliteration, it's associated with an increasing post-procedural pain. So the newer caster is a radial fiber tip, which is a water-specific laser wavelengths 1470, appears to reduce the post-operative pain and probably due to less perforation of the venous wall. Here is the caster of the laser fiber, and here is the unfolding of the caster. Here is the machine. We have several machines, hundreds and hundreds of companies offering these laser machines. So it's the most popular modality in ablations. Here is the radial fiber. You can see here the tip of the radial fiber, the lights of the laser. It gives us this appearance. This is the appearance of radial. So the ultrasound beam runs radially, not directly forwards. So it causes perforation or cause injury of the common femoral vein. And you can see here, we can monitor the procedure or the ablation on the patient. We are seeing the lights across the skin of the patient. You can see here how the laser works inside the vein. Here's another machine of the laser. There is a steam formed by the laser beam to ablate the venous wall, and we can see here no perforation as the steam doesn't go in the tissue surrounding the vein. Now to the microwave. It's a Chinese technology formed by a Chinese manufacturer. Here's the setting of the microwave catheter. is a short heating element, about 1 centimeter, and it looks like laser, but we ablate 1 centimeter by 1 centimeter, not like radiofrequency, a long segmental ablation. After we introduce the catheter as usual, we start the ablation. You can see here the heating element of the microwave ablating 1 centimeter by 1 centimeter in a short interval, about 5 to 6 seconds. And here is the appearance of the ablation, also by steam, and there is no perforations. After we finish the procedure, we wrap the patient leg by compression bandage or stocking for about 7 to 14 days. As we have told you, it's an outpatient procedure, no anesthesia, so the patient can take rest after 30 to 1 hour, 30 minutes to 1 hour, then go back home and start ambulation and moving. He can go back to his work the next day. Here the images after ablation. You can see here the total occlusion and obstruction of the great saphenous vein, 2 centimeters away from the saphenofemoral junction. Also, we can see here the junction is competent, and here is the superficial epigastric vein, no reflux across the junction, and total ablation of the saphenous vein. Here is an axial view. You can see here the vein is non-compressible, totally occluded, without any pain or complications to the patient. Here's a large vein ablated, is a short saphenous vein with no complication to the popliteal vein and competent saphenopopliteal junction. Here is a follow-up after several months. You can see here that the vein is totally fibrosed. You can see the vein in the compartment, totally fibrosed and non-identified. And here is the junction, also competent with no recurrence in reflux. After 1 year, you can see the vein in the compartment, totally vanished. So let's talk about occlusion rates. According to the European College of Phlebology guidelines, you can see here the overall success of the RFA and EVALA, the laser and the radiofrequency, are near 100% and totally similar and similar to each other. This is a paper published with me and my colleagues about long-term occlusion rates. What about complication? No major complication, no DVT, no paresthesia, no phlebitis, but we can see here that the laser ablations have more bruising and more pain to the patient after the procedure. So according to the European College of Phlebology, they recommend endovenous thermal ablation as a first-line treatment for saphenous vein incompetence with a level of evidence of class 1 level A. Different publications in the literature showing that the comparable occlusion rates between the EVALA and RFA. Also, another publication comparing they both are equivalent in occlusion rates. Different publications. Also, most of them concluded that they have similar complication with a lesser similar occlusion rate with a lesser complication rates. Here is regarding the microwave ablations, radiofrequency ablation, and also the microwave ablation. So finally, I will conclude that endovenous thermal ablation has become the first treatment option for truncal varicose vein. It's a minimally invasive procedure. It's done on an outpatient basis with no significant difference between thermal ablation modalities regarding the success rate and the complication rate. Thank you for your attention.